of patients may require interventions after LPJ, but this is because of an inadequately done LPJ. If you do the LPJ correctly, you open the entire pancreatic duct to the tail of the pancreas and clear the duct of all the strictures and the stones and do a wide drainage operation. So with this, it is very unlikely that there may be any problem in the future because you have opened the entire pancreatic duct. The restricture rates will be higher if the pancreatic duct diameter is very narrow, because then the restrictures can be higher. And generally, we don't prefer to operate in normal sized pancreatic duct. So the definition of a dilated pancreatic duct is more than 8 millimeter. These are the ideal patients for a surgery. But nowadays, even with a 5 to 8 millimeter duct, which is an intermediate, mildly dilated duct, people have ventured into surgery, though the results will not be as good. And less than 5 millimeter of a pancreatic duct, we generally never would like to operate. We would never do LPJ because these are the patients where the restricture rates will be high, the relief of pain will be much low. So these are not the ideal candidates for doing an LPJ. So if LPJ is correctly done, it is very rare that reintervention may be needed. But as you rightly said, yes, in practice, we will get some reinterventions because of inadequately opened pancreatic duct. That is probably one of the reasons. Or proper selection of the case is not there. It is done for small duct disease. So I asked Dr. Nageshwar Reddy also for a small duct disease, is this, because this is the cases where surgery doesn't give good results. And he says even endotherapy doesn't give good results in these patients. So we don't know what is the best treatment for them. I don't know what is the right treatment for those people.
Role of transplant? Transplant, sir?
Transplant is, total pancreatectomy and autologous transplant can be an option, but generally pancreatic transplant is not the treatment for chronic pancreatitis.
Yes. So, sir, Dr. Saurabh is also there. If there are any questions in the chat box, you can ask to Dr. Saurabh or Dr. Sanjeev Haribhakti. Dr. Saurabh, are we audible to you? Dr. Saurabh?
Yes, I can hear you.
Yes.
I'm sorry I
Sir,
missed the presentations from the surgical standpoint, just because I was on way to the hospital. But happy to answer any questions and comments. Yes. Is it on?
From audience.
We were looking to having a mukke war with you, and you ran away.
Should I start history? Dr. Saurabh, Dr.
Yes,
Anand,
yes, please go ahead.
Auditorium.
Yeah, we are audible.
We would like to take your opinion also. How many in your clinical practice, the patient who have undergone surgery for chronic pancreatitis and been referred to you for the persistent pain? Is there any experience you want to share?
So who have been referred to us back for what?
After surgery, phrase surgery or LPJ, and they have been referred for you for some kind of intervention. Like post surgery, their pain or calcification or stricture, any kind of surgical complications or the stone not been retrieved, and you would have been gone endoscopically and done some intervention.
No, I can recollect 2 patients in the last 4 months which have come after the surgery, with one patient having inadequately performed surgery, having recurrent pancreatitis and a walled-off collection, and another patient having recurrent episodes of pain. But it's, if you look at all chronic pancreatitis, very few actually require intervention because most of them are asymptomatic and can be managed with conservative treatment. So the number of patients, although is very high with chronic pancreatitis, those requiring intervention are actually a substantially smaller proportion of patients.
Because there are several causes of pain we need to evaluate before jumping on to reinterventions. Because in pancreatitis, only 80% of patients have ductal hypertension as a cause of pain. And a lot of other patients will have neuropathic causes, a lot of other ischemia, pancreatic inflammation, parenchymal inflammation, a lot of other causes for pain in chronic pancreatitis. So we need to evaluate really whether they have any ductal obstruction persistent before we jump onto an intervention.
Yeah, no, that's true. And I think I remember a case recently, a stone in the head of pancreas, but despite stenting, she did seem to have some degree of pain, and she had dyspepsia in addition. So, or it could have been sort of a neuropathic pain. It sounded more like dyspepsia to us. So it's always prudent and important to rule out any other cause of pain. And as I discussed, neuropathic pain is prevalent. I think it's more in the Western context where long-term chronic pancreatitis patients with alcohol, smoking, these guys have a lot more neuropathic pain. And opioid use is much more prevalent in the West compared to India. So that's what also sort of contributes to the long-term disability in these patients. Yeah.
Yeah, so with that, we'll conclude this session and we'll go to the live demonstration of the case by Dr. Saurabh Mukherjee. We would,
Candidate करके contrast डालेंगे. Yeah.
Harwani sir would like to say something.
So now we start the next session on demonstration of pancreatoscopy. I again repeat, post lunch there will be quiz. For those who have joined virtually, you can answer in the chat box. So it popped up and then we will decide about the results and everything. So those who have joined virtually, they can answer in the chat box. And those who are on site, you will get a answer this question and answer paper also.
Okay, hi, good afternoon, everyone. So now that I've made many strong comments and points,
Saurabh,
Yes.
just a minute, sir.
Sure,
Saurabh,
sure.
just a minute. Yeah.
इसको angle बराबर करो. छोड़ो.
I would
Thank
like
you,
to
moderators.
ठीक है? और
I would like to invite the moderators for this session. We have Dr. Manish Gandhi,
open.
Dr. Vinit Chauhan,
अरे perfectly उल्टा
and
है.
Dr. Shreya Putela.
Should I start history?
Yes, please.
Live demonstration of case PD calculi lithotripsy by pancreatoscopy. This case will be done by Dr. Saurabh Mukherjee sir, Midas Institute of Gastrosciences, Nagpur.
Open. Okay, hi, good afternoon, everyone. I'm Saurabh Mukherjee. We had a we'll pull out.
Razia
I think
Bank,
it's-
46-year female, history of chronic pancreatitis,
नहीं यार,
MRCP
निकाल
seen of multiple intraductal calculi, ERCP done in December 2020, seen proximal PD stricture dilatation and partial PD clearance done, ERCP done in May 22, multiple filling defects with stricture in head region on pancreatogram, stricture dilatation and partial PD clearance done, 7 French stenting done. Plan pancreatoscopy and SOS stricture dilatation and lithotripsy for any remnant
open.
stone and biopsy from the stricture.
राजपूत अच्छा वाला देना,
Learning
थोड़ा बड़ा वाला
points,
देना, जो
use
आप-
of pancreatoscopy and SOS lithotripsy for PD calculi and biopsy of PD stricture. Thank you.
Okay, so very good afternoon to all of you. Live fluoro, please. So we have this lady here with chronic pancreatitis, and can we get another actor, please? दूसरा है क्या? ये नहीं होगा. Yeah, hi. So this is a lady with chronic pancreatitis, has a prior 7 French stent placed, and what we are going to try to do today is to do pancreatoscopy. So I made a very strong argument, clearly. And now it's my turn to demonstrate this to all of you. We are having some issues with the rat tooth forceps, so I'm going to get a new one. ये चाहिए था ना? Yeah, so this patient has had a 7 French stent placed in the pancreatic duct. Now I've not performed the prior ERCP. So what I will do is after removal of this stent, we will go ahead with open contrast pancreatogram, which although I do not always recommend in these patients. Okay, I'll try to get it out like this. Yeah. Thank you. ये चाहिए था ना? Okay, so. Okay. So just what we typically do at our center, what I do like to do in these patients is put a 10 French stent if possible, because what happens in these patients is you have to advance the pancreatoscope, which is a 10 French instrument. So if you have a stricture or narrowing, then you ideally want to dilate it and get a 10 French stent in place, because that will generally permit the passage of the pancreatoscope without much difficulty. Wire, please. Wire.
Dr. Saurabh, Dr. Manish Gandhi here.
Yeah.
As this patient has a two private previous ERCP and still she doesn't have pain relief. So in this kind of patient, what are your basic investigation, and according to that, how will you decide that this patient will do a re-endoscopy or maybe
अरे,
you
रुको,
subject
रुको,
for the
रुको,
surgery?
रुको. एक second. So sorry, I apologize. So your point is whether this patient, if the patient did not have pain relief, what else would you do? So I think the first important point is if we are believing in the ductal hypertension theory and adequate stenting is performed, then by and large we would expect pain relief. And in fact, it's a very important thing to do is to place a stent and see contrast, live fluoro, to make sure that there is actually a pain relief before proceeding with any major interventions. Definitely at our center, we don't do surgery unless a stent is placed in the pancreatic duct and there's pain relief. Okay, fluoro live. So we're getting a pancreatogram here. Fluoro live, please. Okay, okay. Sorry, can we? Okay. Pause first. Thumb. ठीक है, no problem. We'll just go back again. You think there's a stone there? I think it looks pretty good, actually, you know. And this is supine, na? इसको prone कर सकते नहीं क्या? Actually, I forgot I should have done her prone. That's why I was thinking there's something off. Yeah. So. Yeah, it drained pretty fast. I think the job is probably already done, but thank you.
Can we see that recent MRCP or CT images if it is available?
If the team can show. Oh, so also just a little word here. This patient, actually we started in a supine position and it didn't strike me as I was occupied with the rebuttal. So my experience performing pancreatoscopy or cholangioscopy supine versus prone. Yes, you can do supine if you really have to, but that's not my preferred approach. And I feel personally in my experience, whenever you do it supine, these patients tend to actually, the SPY scope tends to fall out very easily, and it's a little harder to maintain it. That's been my experience. Can you flip the images, please? Mirror. Left, right, kar do. So I think that's the reason why we are having some trouble with the scope steadiness. And now we have access to the pancreatic duct, and what we'll do is first get a gentle pancreatogram. And again, some basic tips. Okay. Aram se. Okay, thoda contrast dalo. So let's first get the distal end in the head and the neck region, the pancreatic. Yeah, so looks like Yogesh has probably done an excellent job here. I see. So I'm going to go up and get a pancreatogram of the body and tail region now. So let's get negative, please. Fluoro. Okay. So let's go and see the fluoro. Okay, contrast again. Contrast. Okay, so we are going to get a pancreatogram just to get an idea of what we are dealing with. Now what I can see is there's a little bit of a rest filling defect in the head, which is small. And then there's a stricture at the neck. And that's really what I'm looking at right now. There's no big stone in this particular patient. Okay.
Sir, we don't have the fluoro here.
Oh, you don't? Okay. We'll just show you the fluoro images. Contrast dalo, fluoro live. Fluoro live, 1 minute. Contrast. Wire nikalo.
So there is no definite filling defect here, what we can see in the pancreatogram.
Yeah, I think initially I thought there was a filling defect in the head. Fluoro. Contrast, yeah. Okay, I'm going to pull out, contrast, thoda dalo. Contrast, fluoro live. Okay. Fluoro live. Chalo hai. It's okay.
And so do you think the size of the duct is adequate to for the cholangioscope or the pancreatoscope to go in?
Sorry, Sandeep, can you please repeat the question?
The size of the pancreatic duct. What do you think is the size of
so you know, look, see, let's understand. Normal patients should have a 3 millimeter diameter pancreatic duct in the head, 2 in the body, 1 in the tail. This is what a standard patient has. And your pancreatoscope is 10 French, which is 3.3 millimeters. So, just 1 second. आप please wire डाल दीजिए, and हम dilate करेंगे 4 या 6 के balloon से, थोड़ा सा. हाँ, तो
Because at the neck it looks difficult, like there is a stricture.
Yeah, it's these guys. Fluoro. Okay. Further tail towards that spine we are not seeing. I don't know if it's atrophy or what. I put contrast there 2 times. So yeah, so you know, Sandeep, as we were discussing, 3.3 millimeters is what the diameter you require. So therefore, you should not be doing it in a multiple strictures because that will require multiple settings. Or you can have dilation done successfully to 10 French. Yeah. So or you can have dilation done successfully to 10 French stent, and then you can advance the scope as much as possible. And now what I'll do is, go ahead, let's do a wire here, and then we'll dilate it to get the scope in. Okay? So we'll get the wire. Right, so basically, I typically start off with the initial ERCP, put a stent in, assess if there's a response. Probably in the same setting, if I can put a 10 French stent, why not? If not, then I go ahead and get another setting done where I dilate and get a 10 French stent in. And probably immediately after, or you know, the following day or so, you can take the patient for pancreatoscopy. Now, I don't like to do the dilation typically on the day off, because what happens is there is some oozing and bleeding, and that can make your views sort of inadequate. So my preference is to perform dilation stenting previously before, so that what it does is, you know, on the day of pancreatoscopy, everything is clean, and you can just have a good visualization. Now what we'll do is try to get a guide wire deep inside the pancreatic duct, yeah? So please, fluoro. Good, good, good. Okay, chalo, I'll go ahead.
Because the dye has drained, all the dye what you have put has drained.
Okay, very good, very good.
So I
Chalo,
think
wonderful. Exchange.
there is no obstruction.
Okay. Yeah, so let's see, I think Yogesh has already done a fantastic job in probably clearing the duct. So we will go ahead with pancreatoscopy visualize, because I do feel that sometimes, you know, ducts are missed, stones are missed. And I think, therefore, going ahead with visualization is not a bad idea. Because we all know that your cholangiograms are not 100% sensitive in picking up stones. So let's see what we find.
Sir, just a question. Like you said that you first put the stent, dilate, and then go for pancreatic. So what is the time interval between these two?
Sorry.
Both the
I apologize.
procedures?
A little bit of noise in the room. 1 second. Boss, please lower the... I can't hear
Dr. Vinit, please.
Yeah.
Sorry, could you please
can you
repeat
hear
the
me?
question? I couldn't hear.
You said that first you put that, you try to put the 10 French stent, and
Uh-huh.
then later, at a later date, you go for a pancreatoscopy.
Yeah.
What is the time interval usually in your patient?
See, bottom, I mean, you can do it pretty much in the next couple of days if that's what's convenient for the patient, or you can do it at a later date. The point what I was trying to make was, whenever I've had to dilate it, there can be sometimes oozing following dilation, and that limits your views when you're doing pancreatoscopy. Now remember, pancreatoscopy is different than cholangioscopy. You know, what do you have a dilation? CRE कितना? 4, 6. CRE नहीं, मेरे को hurricane चाहिए. 4 or 6, whatever. 4, fine. Yeah. So, I apologize, I lost my train of thought. So yes, so what I was saying was, pancreatoscopy is very different than cholangioscopy, you know. Basically because it's a very narrow space. It's not a big space compared to bile duct, you know. And there's a limited space in these patients, and typically you don't want anything obscuring your views. So dilations, etc., especially you're doing this a lot of times for the stones in the head of pancreas and the neck of pancreas, and then you dilate it right there, and then there is oozing and edema, and you know your scope doesn't go in, you can't see, can actually cause some difficulty. Although in this particular case, we are going to dilate it gently today. Hopefully, we will not have much of a trouble. Just because this particular duct is not very dilated, and that's the thank you. yeah, in this particular case, the duct is not very dilated, and therefore I'm resorting to dilation in the distal part to facilitate passage of the scope. You know, yeah, and if we do see some stones, I'll explain to you how I do lithotripsy in these patients and how the technique is a little different from yes, inflate please. How the technique is a little different from your bile duct stones. So, the first thing when you look at stones in the pancreatic duct, they're white and they're hard compared to bile duct, which are, muddy brown color. And the stones in the pancreatic duct are typically adherent to the walls, and sometimes they can have sort of calcifications extending into the side branches. So what we are trying to accomplish is the main duct clearance. Now what I typically have to do is target my EHL or laser towards the periphery where I get the stone mobile and away from the wall. That's like the first thing I try to do. And subsequently, once it's mobile, these are not huge stones. These are like 1 centimeter, 1.5 centimeter stones. So typically it's never a big problem doing the lithotripsy, in the sense that the time required for lithotripsy is not much versus say a 2-3 centimeter bile duct stone, which can actually take a little longer. Okay, now. Yeah, so we are doing a CRE here. We are doing a 6 millimeter CRE. Okay.
So Dr. Shreya over here. So for pancreatic duct stricture dilatation, do you place only a single stent or multiple stenting is done?
Yeah, good question. I think that's a very important point, and I think everybody needs to, whoever is doing ERCPs or ERPs, if I may say, need to be cognizant of how stricture should be managed. I think the most important thing is to put in as many stents as possible and the largest dimensions possible. Because what you want to do is dilate the stricture and keep it dilated, number one. And second thing is, every time you take the patient for a follow-up ERCP for management of the stricture, your goal is to upsize. Okay. So for example, if you place the 7 French stent in the first, if you put a 7 French stent in the first setting, your goal should be perhaps to put a 5 French and a 7 French, or a 10 French stent in the next setting, because you want to gradually upgrade and increase the diameter. But remember, 7 and 5 French doesn't mean 12 French. It doesn't actually equate to that much. So you have to, if you look at a stricture, a 10 French stent is probably better than a 7 and a 5 French. So you want to maximize every time, you want to upsize every time, and you want to, of course, check every time whether you truly need to, single operator. And you need to also check whether you truly need to put stents in. Because say you have a 10 French and a 5 French stent inside the pancreatic duct, you don't actually maybe need to do further stenting, because that oftentimes should be sufficient to treat the stricture. So once you've achieved that, I think for the most part, patients do fine and your stricture has been treated. Thoda negative, thoda negative. Okay, so we are going to get the pancreatoscope in, and I think compared to the bile duct, I'll show you how the pancreatoscopy is a little different. And let's just see, we are getting this instrument in. Now question again, I think most people would, and I think most people would have questions regarding laser versus EHL when we are dealing with these stones. I'd say both work equally well. I think there were some anecdotal experiences of EHL maybe being a little better. It sort of depends on the availability and the expertise. There are no head-to-head comparison trials. But in my opinion, whatever works for you is fine. Both are equally good modalities when we are dealing with these stones. Okay, so now I'm going to get the scope out. So I'm a single operator kind of guy, and that's how I've been trained, and that's why I just use all my all the instruments in my hand, including the spioscope. Okay. Put up. Can you hold this wire? There's a negative. Okay. And yes, and you know, as we know from the bile duct is sort of relatively easier to get the scope in, and in pancreatic duct can sometimes be a challenge. Now, sometimes you have to go through minor duct in these patients, and actually, I think that's maybe a little easier because it's a bit of a straighter flush. Okay, excellent. Yeah. All right. So, fluoro, please. So remember, when you have a non-dilated duct, you may encounter sort of roadblock.
Can you switch over to the spioscopy image?
Yeah.
Yes.
Can we please do that here on the screen? Can we please show the spy images, please? Yeah.
Yeah.
Are you guys seeing that? Yeah.
Yes.
Okay, so fine. Good.
There is a
All right.
stricture.
Fluoro. You know, so as we saw in the initial views, there is a stricture, and I was not sure about the filling defect. In the initial views, I thought maybe there's one, but I'm not sure there is one. And you see the inner layer inside the pancreatic duct. For those who have not seen this, it looks a little different from the bile duct, and especially in chronic pancreatitis, these patients can have a lot of fibrosis, scarring visibly. And yeah, let's see. Okay, thoda negative dena aise. So I'm going to request our endoscopy technicians to help me with some negative pressure to help me get up a little bit. Fluoro? Yeah, now we have actually managed to traverse that area. Now we are crossing into the body of pancreas, and the wire is coiled here. So let's see, here we go. Fluoro. You know, and this particular patient, the tail is atrophied and there's no sort of contrast going deep inside the tail. So what you will have to, you'll see is the body of pancreas, and then, okay. So now I'm going to, so now I've almost reached the maximal extent of my views. The scope is not going to go any further. And what you saw on the pancreatogram was that the duct sort of atrophies at this point. So here I'm going to pull out my wire once I've reached the maximal extent. Certainly in pancreatoscopy, I do strongly recommend putting a wire and then getting the scope across as opposed to freehand, unless you have a huge pancreatic duct. So here we go. Fluoro. So can you guys see the fluoroscopy views?
Yes, we can see, Saurabh.
Yeah, so now we have reached in the body, the mid-distal body area, and what I'm going to do is move my dials to try to see the best views I can get here. Okay, so first of all, we need to look at the lumen. Now here we are looking at the lumen. Now that's pretty much towards the tail of pancreas. This is the maximal extent for us to view. And you see the lumen is narrow there, it's fibrotic, consistent with chronic pancreatitis. Now I'm going
Dr.
to pull
Saurabh,
back.
can you, sorry to
please do.
intervene.
Go ahead.
Can you pass a wire through that and then dilate this picture?
Well, that's a good question. Let's see. What we can do is put a wire down, but typically the contrast was not opacifying that area. Yes. And let's see. You could get the wire across, but of course your dilation is going to be performed with your standard ERP.
Yes. Standard ERCP.
You know, you see now here's the size. This is the wire, and now you can appreciate the size of the lumen there. It's barely allowing the guide wire to pass through. You see?
What's the status of the gland?
And that's
in
why
the
it's
body
sort
of
of
the
blocking there and not permitting to go across. All right, there we go. Fluoro? Yeah, now this is the area which in fact was not even getting opacified with the contrast. Yeah, and I think the guide wire is not allowing. Let's see, आप डाल के देखो थोड़ा guide wire. So okay, डालो. So I think the duct sort of ends there. I will have to look at the cross-sectional imaging to confirm that for you. But even the guide wire is not going beyond this point. I would imagine this is a tail which is atrophied and duct is sort of ending there. It's not a true stricture, as the contrast was also not going beyond this point. Okay, so we are trying to push it further. Nahi ja raha na? Yeah, so the wire is not going. Okay. So anyway, what I'm going to do is demonstrate to you how the pancreas looks like from inside. For those who, I guess the surgeons who look at it from outside will show it from inside. How does it look? Yeah, so one thing is, when you're doing pancreatoscopy, you have your wheels, you got to look at all the walls and try to keep the scope in the center of the lumen. So we're looking at the distal body here, and I'm going to pull back, move my dials, and it looks pretty beautiful here, I would say. And Yogesh, I think, has done really well. There is really very little stone burden here. Isko nikal do. I don't see any stones left anymore. And what you saw from prior studies is sometimes just placing the stent is enough, spot fluoro, yeah. So this is the genu where we have the acute bend. Fortunately, we could go across and get inside the body, which sometimes can be a bit of a task if the genu is very, tight. So I'm going to show you the last part here. This is the duct in the head neck region, and looks beautiful here. I don't see anything to be done. Let's see, I'm going to pull back more. So these are the more difficult views to obtain sometimes. And I would say, yeah, this can be a challenge sometimes when you're doing laser here, as the most distalmost part. Fluoro, please. Fluoro. Yeah, now we are actually almost at the ampulla. You can see on the endoscopy view, and you can see on the pancreatoscopy view, both ways. We are at the ampulla. There is nothing here to be done. The duct is clean. It's open. And I think, well, I guess it demonstrates that endoscopy can clear the duct. And, not always you need a ESWL or laser. Because sometimes just placing stents and for smaller stones, they can disintegrate and come out.
Sir, how do you deal with the strictures? Like how many strictures maximum you can deal at one session, and like what should be your approach? Like if there are multiple strictures.
See, I think multiple strictures without stones is infrequent, but then if you do have a couple of strictures and there are no stones, you can pretty much deal with all of them at the same setting, because you can keep dilating them sequentially and put a stent across all of them to eventually treat them. But then what you may encounter are tight strictures and stones and tight strictures. And therefore, in these patients, going across, dilating, stenting, doing this can be more challenging, especially when they are tight. You see, in this particular case, this is a sort of a benign-looking stricture in the genu. And as we do, all of us do endoscopies, so we can recognize that it's very fibrotic. And there's nothing really here that would make me worry about a malignancy or so. We all know that chronic pancreatitis is associated with high risk of cancer. But that's typically, this is not a modality to diagnose or evaluate. Biopsies have been performed in these patients sometimes, but by and large, your biopsies are EUS guided when you're looking at pancreas cancers in this setting. Because it's more parenchymal, it's not like an intraductal biliary type situation.
At an average, how many sessions, like repeated sessions of pancreatoscopy, dilatations, like may be required, like if there are about 3 or 4 stones?
Yeah, and, good question. Yeah. So, when you have multiple stones, I think what you require oftentimes is a few settings, and your patients have to be prepared for that before taking them. Generally, if you have like 1 stone, 1 or 2 in the head, you should be able to deal with that in one setting. But if you have strictures, you have stones extending beyond genu in the body of pancreas, then there's a bit of a wear and tear on the scope as you get access to those stones. And typically, I mentally prepare them for 2 settings. That's not the population most people have been doing pancreatoscopy in, as it's sort of a newer way of approaching pancreatic stones. People have generally, by and large, restricted themselves to limited stone burden in the head mostly. But since I've been doing it over the last year, my threshold to do it has gone lower and lower as we've had good success. Initially, we were very, very selective. We said only a stone in the head. We will not touch anything more than that. And then now we have, our threshold has actually definitely gone down, where now we are targeting the body ones as well, and and doing more and more.
So, sir, yeah, madam, please.
For the patients having headstones, particularly what distance from the ampulla is the minimum distance required for the scope and to like introduce and have laser lithotripsy done? I mean, is there
So
any?
you said what distance from the ampulla?
Headstones.
Oh, for the headstone, yeah.
Yeah, near the ampulla.
Correct,
Near the
correct.
ampulla.
That's a good
So
point.
what is the minimum distance which is required?
Yeah, so what you actually have to do is the duct distal to the stone. Remember, that's what you really care about. Proximal to it, it's fine, it's a stricture. But the duct distal to it, between the ampulla and the stone, has to be dilated for the scope to enter. Now, if it's narrow, you want to make sure a 10 French stent is in situ before you do it, as I said earlier. Because see, you have a stricture, what you're going to end up doing is damaging your scope, pushing it across resistance, and you will ultimately not achieve anything. The distance doesn't matter. You need to be able to get the scope in and have a stable position. Certainly, when it's in the distalmost part, and say if it's at an acute angle, can be more challenging than having it say a centimeter proximal to the ampulla. It can be done when it's at the ampulla as well. Not that it cannot be done, but obviously catheter dalna is. Sorry, excuse me. You want to put stent? We can. Yeah, I will just put a 7 French stent. It's fine for now. I think the stricture is also pretty open. Oh, yeah, I think looks good. You want to just leave her stent free?
Yeah, I think Saurabh, there was a stricture, so you can place a stent right now.
Yeah, I think I may just put a stent.
Yeah.
The point was also that the 10 French instrument went so smoothly across the
Yeah,
area.
so you place a 10 French stent this time.
Yeah, fine.
Yeah, so there is a stricture, it will help to dilate further.
So I think we had a 7 French, so we'll upsize it to 10 French today, and that will facilitate. But again, if a 10 French instrument can go across easily, then a normal pancreatic duct has a 3 millimeter diameter in the head. You achieve that, I think you are in good shape. But we'll do a 10 French stent, and then we'll take it out later. I anticipate she will not require much beyond that point.
So any questions on pancreatoscopy? Sir, if there are any virtually asked questions, you can see in the chat box, sir. Okay. So we take a break for lunch. Is there any question? Yeah, please.
Dr. Saurabh.
Yes, hi. Yes, please.
Yeah, hi. To me, this is like a negative laparotomy. You did a procedure, we didn't find anything.
True.
So I would like to say, would you have preferred EUS before doing this pancreaticoscopy? Unnecessary pancreatitis being caused by an intervention into the duct.
Yeah, good
or
point.
Maybe a better MRCP to find out what exactly.
Right. See, here's the thing. You have to approach with a non-invasive manner first. There's no doubt about that. And endosonography or MRCP are certainly acceptable modalities to look for stones. However, one thing I would like to also sort of refute or reduce the apprehension in the audience in general is actually the risk of pancreatitis is actually quite low in my experience. And I've just not seen it much. These are chronic pancreatitis patients, and when we go with pancreatoscope, yes, we are flushing water. We expect or we think that it can be a sort of a high risk procedure, or we're going to cause damage, but it really doesn't. I mean, these patients do fine, especially the chronic pancreatitis ones. If you remember from our ERCP experience in in native papillas, and the ones who get pancreatitis are those have a certain phenotype. They're not our patients, young females are the ones who end up getting pancreatitis for whatever inexplicable reasons. But these chronic pancreatitis ones, they just rarely have pancreatitis, I must say. But yes, your point is well taken. I agree with you. A non-invasive modality should be preferred before any invasive modality is done. Yeah. I think there's more apprehension about pancreatoscopy than actually there should be. That's my feeling always.
No, because the concept is that pancreaticoscopy is more of a therapeutic modality rather than a diagnostic.
Yeah, absolutely. I would not do it as a diagnostic modality. क्या हो रहा है? गया क्या? Fluoro? दिख नहीं रहा है पे.
There is a question from audience, Dr.
है क्या?
Shrikant.
अच्छा ठीक है, negative. Release करो, release.
So.
Sorry,
Dr.
yeah,
Saurabh,
please go ahead. Yeah, we are here.
Yeah, so there is a question. Is dilatation of MPD to more than 3 to 4 mm by putting multiple stents is non-physiological and associated with pancreatic pain in these patients?
3 to 4 stents?
I mean, dilatation of MPD to more than 3 to 4 mm.
Oh,
by
I see.
putting multiple stents is non-physiological and associated with more pain.
I think that's an interesting point. And I always wondered myself that we are dilating it to 6 millimeters. But here's the thing, they don't end up having any problems by and large. As we always would think that, it's 3 or 4 mm duct, and are we doing justice by dilating it to 6 or 8 mm? But usually up to 6 mm, they don't end up having much of a problem. And certainly I've not seen them have post-procedure pain, so to speak, if that's your question. And yeah.
And another question, are PD stones difficult to break compared to CBD, and how much longer time does it take?
Actually, no. I don't think so. I think PD stones work, they break quite well. And in fact, sometimes okay, that's it. Iske upar nahi jayega. So I'm going to deploy the stent here. This is it. The stent's not going to go further. Okay. So yeah, I think it's not different. I think the technique is different. You have to remove the adherent stone to the wall. I think that's the key, because that's a little different technique there. In fact, these stones are smaller. And in fact, in some patients, I think it is easier to do PD stones than CBD stones, because they are smaller stones, and then once you remove them from the wall, they just keep floating, and then you can just get them out. So not worse, not more difficult.
I think we conclude.
So
thank you very much. A very nice demonstration of pancreatoscopy.
Thank you so much for having me.
So post lunch we gather here at 1:45. We'll have a quiz first. For all virtual people who are there, please join us at 1:45, and you can place your answers in the chat box. Okay, so we meet at 1:45 again. Thank you.